Yeah, so as Ian and Stephen said, I'm Lucy Heath. I'm Academy Director for the Black Country and West Birmingham Strategic Transformation Partnership, or Healthier Futures Partnership. So I thought I'd just start off by saying a little bit about the Academy before I go on and say a little bit about the priorities for the Healthier Futures Partnership. And then at that point, Stephen's going to come in and share some of the stuff that he's been focusing on as part of that, and then say a little bit more about kind of the governance and infrastructure he's hoping to set up and involve you all in to take that forward. Please feel free to interrupt me at any point. I didn't really know how you wanted to do this, so I'm more than happy to do this more conversationally if anybody wants to butt in at any point. So yeah, just to say that the Academy is about supporting the Black Country aims, which are threefold. So building healthier and happier communities, making the Black Country and West Birmingham the best place to work, and being fit for the future. I've got this in the wrong order, sorry, I tried to. This was supposed to be in a different order. My apologies, can I start with this bit? Right, so like I said, I wanted to say a bit about the Academy. So the Academy has been set up by the STP to support population health management in the system, and population health management to me is about making choices matter for the health and well-being of people in the Black Country and West Birmingham. And just to go into a bit more detail about that, that's about choices at every level of the system. So as a system, we really need to have high quality decisions informed by the needs of the people we serve, and especially the most vulnerable, so that we can be held accountable for our strategic outcomes and priorities. So there's that bit at the system level, which is about developing our strategies. There's about choices at a place to make sure we've got high quality decision making and operationalising those strategies. So that's about, are we designing effective interventions? Are we collaborating with our health and wellbeing boards and the strategic commissioners? There's those choices at a neighbourhood level, which from an NHS perspective, we often talk about primary care networks, but neighbourhoods in any sense, about how do we implement our effective interventions and make sure we share our intelligence that we gather with place and system. And then there's the choices at an individual level to make sure that they've got high quality decision making in making sure that we're preventing avoidable ignorance from the patient about what's possible in terms of interventions and treatments, but also from the clinician about what's valuable to the patient, and therefore reducing that kind of harmful or wasteful overuse or underuse with certain populations. We know this is more likely if we have good leadership, good culture, if we've got data infrastructure so we can link our data and share our data, if we have stewardship for our workforce that can support this type of work. It's more likely if we're generating actionable intelligence so that we understand our population need, that we have tools to look at the specific needs of certain subgroups, and if we understand where we might have opportunities for improvement, and that might be because we're different to another area or we've got differences within the Black Country and West Birmingham. And we really need to understand that those differences might be warranted, so it might be acceptable because patients have different priorities and choose different things, or it might be unwarranted because it's about our processes and our pathways and how they're different. Then it's more likely if we're actually designing effective interventions. So it's really important that we have the evidence to support that we're using design thinking, that we really importantly learn from the people we serve, that we're evaluating that at every stage, and we're accountable for the success of that at every level. And then finally, we need to focus on the 4 pillars of population health, so not just about services. So we need to be thinking about the wider determinants of health, our health behaviours and lifestyles, the places, communities we live, as well as that integrated health and care system. And underpinning all that, we need to be thinking about inequalities. So this is what the Academy's been put in place to try and get all these bits in place. It's very, very early days. I started as Academy Director in August. I have a budget to have a team, but I haven't recruited yet. So as of today, it's still just me. I'm hoping over the next 3 to 6 months, I will have a team, but it's proving slow progress because lots of the support around HR that I need is being invested in the changes that are going on with the CCG going from 4 to 1. So it's slow progress. But that is the goal, and this is just kind of the vision for the Academy, that actually trying to get us from focusing on individual services to thinking about populations and population segments, stop using single sources of data and focusing on it for performance management, and looking at bringing all our data together and thinking about our population health improvement stop having individual view of resource use and the competition, and try and make us work as more of a collective in thinking about the stewardship of our resources, not just taking into account the highest paid person's opinion, and actually having data-driven, intelligence-driven decision making, not worrying about cost and reacting to things and doing things to patients, but thinking about value and predicting people's needs, thinking about the wider determinants and how we serve and do things with populations, and not just implementing top-down national mandated changes, but actually thinking about how we develop things locally and how we do bottom-up experimentation, how we have more innovation, which is obviously something as a voluntary sector which is really your strength, so how we encourage more things like that. And Stephen shared this slide with me the other day, and I just like it because I talk a lot about data, but when I talk about data and intelligence, I don't just mean the numbers. I'm really keen to try and get much more qualitative data or stories that actually help us understand what's happening, people's experience, but also on what we can do to improve things and what strengths people have themselves to improve things. So I really like this because this kind of shows a shift in terms of intelligence, that we're not just talking about numbers, which we invest a lot in, and we have a lot of analysts that can do things about numbers, but we want to try and make sure we're getting much more intelligence in the form of stories and thinking about how we can use that more effectively. The population health management in the academy isn't actually what we'll do. That will come through other strategies. So I do a lot of work supporting the development of strategies, and a lot of what I'll talk about in the next session is what we think will be in those strategies. So at the moment we're looking at the clinical strategy, a health inequality strategy, and also the people's plans being refreshed, and we're trying to inform all those and also try and make them work together. And then we also need to influence those enabling strategies like the finance, the digital and strategic commissioning. So I'm working with all those people to try and support that. And that's then what I wanted to share with you about where some of those thinking is. Shall I pause there in case anybody's got any questions, or would you like to just carry on?
I think probably, Lucy, if we go to the end of your presentation and then perhaps pause there, seems like a good plan.
So in terms of the priorities, these are all set around the 3 aims that I shared at the beginning that the Academy is focusing on as well. And what we've done, and I realise this is a bit small, but we've developed a really high level system outcome framework. So we've got bits around each of those 3 high aims. And the best place for work, for example, is based on the people's board and their priorities. So things like improving leadership and culture, improving workforce supply, education and training, flexibility and support. The fit for the future is coming through the stuff that the finance teams are doing around making sure we're sustainable. But the bit that I probably focused on most is this healthier and happier communities. And again, like I said within the Academy bit, it's about the 4 pillars of population health, not just about services. So really trying to encourage more of a move to thinking about wider determinants of health, our healthy behaviours and lifestyles, the places and communities we live, as well as our services. So that's our kind of high level outcome framework. And it is high level and there's lots of opportunities to influence it, and there will be variations at place. So there's really lots of opportunities to get involved in kind of influencing what kind of outcomes get set on that. But the real key thing is that as a CCG in the future, they'll be looking to commission based on outcomes rather than kind of on kind of more performance management type measures. So the second thing to say is we've been looking at segmentation, and at a really high level thinking about 4 segments of our population. So children, young people, healthy adults, adults with long-term conditions, and then comorbidity, frailty and end of life. And I think this piece of work kind of highlighted that generally we focused on adults with long-term conditions and comorbidity and frailty and end of life, and we haven't thought enough about our children and young people and our healthy adults. So the other hope is that this segmentation will encourage us to think more about those other parts of the population and how we support them to be healthier and not to move into those other 2 segments if possible. So because we didn't want to procrastinate, we're trying to focus on at least 1 key outcome and 1 inequality priority for each segment in the next year, while at the same time trying to do more engagement work around some of our strategies. So this will be the process hopefully for the clinical strategy and the health inequality strategy, is that we'll try and make some immediate plans to get some stuff done based on intelligence we've already got, while at the same time we gather more intelligence and do more engagement to work out what the strategy should be moving forward. And there's a real kind of ambition to align with the places health and wellbeing strategies, because there's huge overlap between the CCG and the SDP and what will be the integrated care system and the health and wellbeing board's agenda in each place. So this is just current thinking, and this is my summary, so please don't hold me to this, but I just wanted to share where I think things are up to. So with children and young people, the focus for the next year will be on maternity, school readiness and mental health. And the reasons for that is we have work already going on in maternity. We've been commissioning a piece of work around mental health with the strategy unit as part of something called the Decision Support Centre. And we've been starting some work on school readiness that we think is really important. And in terms of inequalities of this, we'll probably try and focus on our most deprived wards. With healthy adults, the focus for the next year will be smoking, and that's mainly because we're getting funding for smoking. So we need to have NHS commissioned services for any inpatient or anybody on the maternity pathway or anybody in mental health services. And with this, we're thinking we'll try and focus on the wider determinants of health, and I'll come back to wider determinants of health in a minute. For adults with long-term conditions, we're thinking about focusing on cancer, cardiovascular disease and respiratory. And this is because if you look at our life expectancy gap, those are the three conditions that explain most of that life expectancy gap. And we're thinking about having a focus on people in contact with mental health services, because we know that their life expectancy is 18 years less than the general population. And we know that they don't die from their mental health problems generally. They're dying from cancer, respiratory and cardiovascular disease. So making sure in our inequalities we have a focus on that cohort. And then in the final segment, we'll be focusing on end of life. And again, that's because we've got a really good report on end of life with some really good intelligence we can build that on. But we need to think more about the inequalities we'll look at in that area. So like I said, I wanted to say a bit more about the wider determinants of health. So this is one of the first projects that the Academy looked at. So we produced a report which looked at the connection between wider determinants of health and health service use, and then the impact of COVID on those. And the really clear messages that came from that is the Black countries never had really good wider determinants of health. We suffer more deprivation, and that does have a big impact on our health service use. But with COVID coming in, COVID's impacted on that in a number of ways, both in kind of immediate health service demand, but also on the fact that we know it's going to have an impact on things like employment, and then that will have a secondary effect on people's health and therefore their use of health services. And probably one of the most stark messages that came out of that was it'll be quite a major increase of kind of around 15% increase for physical health services, but even higher, around the 25% mark for mental health services. So we finished that report in about October time, and since then Stephen and I have been going and talking to various groups about the reports and getting people's feedback. And I'm taking a paper to the SDP board in March. It was supposed to be January, then it was postponed to February, and now it's March because of COVID taking over the agenda. But we have 5 recommendations that we're going to put forward in that report. So the first is about taking actions together as anchor institutions. And I know in Wolverhampton you've already started some work with an organisation called CLES, which is led by the local authority. So what we're actually doing is commissioning similar pieces of work where that's not happening, and also a piece of work that kind of looks at whether the work of the 5 networks could come together and add value. Looking at improving access and outcomes of people with mental health needs. Now, the Mental Health Trust has led on a bid to get quite significant funding for community transformation. So it will be about how we make sure wider determinants of health is built into that and how we work alongside them, but also about how we get other parts of the system to think more about the physical health of people with mental health needs, because as I said before about the gaps in life expectancy. Something around the best start in life for children and young people. So like I said, focusing on that school readiness outcome, which is a kind of signal that we're hopefully doing things better in the first 1,000 days or up to 5. So we have a children and young people's group that's part of our new board, which is the Health Inequalities and Prevention Board. They've been refreshed, but they've been established for some time. So we've got a number of projects that they're already working on, but we're also trying to influence the CCG to invest more money in that so that we can do more to support children and young people in their first years. One of the engagement bits we did around this we called community conversations. So Stephen designed and organised this, and we had over 70 people joined a community conversation about health inequalities and some of the findings of the report, and it was really, really successful. So another one of our recommendations is to try and continue those community conversations. we're going to do it before we make the recommendation, because we've got our second one tomorrow, and we've also found some funding to try and support this work, but we'll need to encourage the SDP to and all the partners to look at this as well, because that will only get us going. It won't be able to sustain this in the longer term. And then finally, influencing the health inequality strategy, trying to make sure we're focusing on the groups most impacted by wider determinants of health.